Well, thank you all for coming this evening. I'm Krenzel. Some familiar faces here I've seen at previous educational lectures, some folks that I work with at the hospital that I've never seen in civilian clothes, so way to go, Mary. Way to dress up nice. Michelle, thank you for setting this up, and I'm happy to be here, happy to hopefully teach you all something tonight. And we'll go through a little talk, try to explain a little bit about what hip and knee arthritis is. A lot of people have misconceptions about that, so we'll take a few moments to educate you on what that is. Then we'll talk about some basic treatment options, non-surgical treatment options, and then the surgical treatment options. And I'll tend to focus a little bit about the minimally invasive anterior hip that a lot of you may have read about or heard about or know people that I may have done a surgery on or had done elsewhere. Then we'll talk a little bit also about minimally invasive knee replacement, in particular partial knee replacements, a little bit tonight. And some folks in the audience may have had knee replacements or hip replacements. I know some people have had that done before. And I'll kind of try to outline some of the differences between traditional approaches, traditional surgeries, and the newer techniques. Just by a way of little education about myself, this is what I do. I've spent the bulk of my adult life educating myself to become a physician, but particularly a surgeon, an orthopedic surgeon. I was often asked on the interview trail when I was going through residency, well, what would you do if you weren't an orthopedic surgeon? And my simple response was I would be a general contractor and build high-end homes. So all I've done is take that and turn it into the sterile environment of the OR. Specifically, I've gotten interested in hip and knee replacement during my education, and I did a fellowship up in Indianapolis for a year. That's not required. I finished my residency. I was legally licensed to participate in medicine and general orthopedic surgery. I had passed my board exam. But I chose to move my family up to Indianapolis and spend that year focusing on hip and knee replacements and the intricacies of those surgeries. And I think it does offer patients a little bit more when we have a particular skill set, especially nowadays. Y'all's expectations are higher of us than they've ever been before. And quite frankly, the government's expectations are higher of us now than they've ever been before. And those two things are going to put a lot of pressure on physicians across the board to produce a product that is excellent outcomes and at a low cost. That definition is value. And I think as a specialist, we're able to deliver that value better than non-specialists. That's not to say that somebody can't do a good hip or knee replacement if they're not a specialist. But the way healthcare is going, it's important that you consider these things in your physician and surgeon, okay? So we'll start with basically what is arthritis. And so I start with the hip and the knee. We'll start with the knee. The knee is a hinge joint, but it moves in all different directions. It rotates, it bends, it twists, it slides side to side. It has a lot more freedom in its motion than what people think. And when it's healthy, it works great. The good Lord gave us a fantastic tool in all of our joints, from our small knuckles to our hips and knees and shoulders. But when there's disruption to that motion, when it doesn't work beautifully, it starts to cause pain, and over the years can lead to some mechanical changes that can cause arthritis. So here we have a cartoon, if you will. And we see, there we go, our red dot's working. Can y'all see that okay? Am I in the way over here? Y'all see the screen fine? So this is a side view of your knee. This is a front view. This is the muscles of your thigh, the top of your shin bone. This white cartilage here is the meniscus or shock absorber cartilage, as many people may have already had arthroscopic surgery to have those taken care of, or have heard of other people that have had those. That's a very common injury in the human knee. This white cartilage here lining the end of the bone, and seen here more in the yellowish color, on the end of the bone, is like the smooth white shiny cartilage on the end of a chicken wing or a drumstick. That articular cartilage, or capping cartilage as I'll refer to it for y'all, that is, when that erodes away, that capping cartilage, that's arthritis, y'all. And it doesn't matter how you get that cartilage erosion. When that tread is worn off your tire, that's arthritis. Okay, and there's different types of arthritis, but that's effectively, oh, that's helpful, thank you. Much better, much better. Plus the camera doesn't have to see my ugly mug. Here we have a hip doing the same thing. And a cut out of the hip, and again there's this smooth white cartilage cap right there, and again on the socket side. All of these are tendons and capsule, not necessarily relevant to what we're talking about today, but when that cartilage cap wears off, that's arthritis. Here's a cartoon of the hip showing in purple. Obviously our cartilage isn't purple. I'm not sure what that disease state would be if it did exist, but purple cartilage here is really white in real life, and that smooth white shiny cartilage, when it starts to erode and wear and thin, You can see the start of the arthritis here in this cartoon. When we move on to kind of defining what are the different types of arthritis, some people have rheumatoid arthritis. Some people have psoriasis and get psoriatic arthritis. Some folks have had traumas to their hips or knees, bad car accidents, fallen off the roof, and they have fractures, and they get what we call post-traumatic arthritis. No matter what it is, we end up with a deformed joint, a stiff joint, and it's all because of the loss of that cartilage. And what ends up happening here in this knee cartoon is we get a stepwise decline in our function. And it's slow and it's sneaky. And it doesn't happen overnight. It takes years. And it happens so slowly that most people don't realize what happens to them until all of a sudden you just can't put your shoe on because you can't move your hip and it just hits you one day. What's going on? Or it hurts to go to the grocery and it hasn't done that before. And this process takes years to occur, but there always is a starting point where it just begins to hurt. And we don't necessarily have to have a specific reason for that. We have the bottom line here on this slide is just saying again, and I'll emphasize it one last time, it's the loss of that smooth, white, shiny cartilage that is arthritis. Most commonly, though, it's just what we call osteoarthritis. And that's just the bone spurs forming, that cartilage loss, and it's a stiff joint with loss of motion, increased pain, and diminished function. So what are the symptoms of arthritis? As I've just said, pain, swelling, grinding, stiffness. I love this slide here. This is from Hallmark. And it says, if you can't read it, there's a guy getting out of his car at the auto shop, and it says, it makes a creaking, popping sound every time I get in or out. And the mechanic says, no, sir, that's just your knees. I live that way already with that same set of symptoms. So I'll show you what we look at a little bit as physicians. I'll show you an x-ray. This is a relatively normal knee x-ray, okay? I want you to notice this is an x-ray of the left knee. So if I'm facing you, this is the left knee. So this is the outside part of the leg over here. This is the fibula bone of the shin bone down over here, just to give you perspective. This left knee x-ray. Over here, we see a thick black stripe on the x-ray. That is normal cartilage. You can't see it on the x-ray. It doesn't show up. But that space, when I look at it or another physician looks at it, radiologist, primary care doc, orthopedist, we see that thick black stripe. We see a nice round contour to the bone. That's a very normal looking joint space for the outside part of your leg between your thigh bone and shin bone. Over here, you'll notice it's slightly narrowed. I don't know how well you can appreciate it but that space on the inside part of this knee on this x-ray is slightly narrowed, okay? That is early arthritis. That's what we see on x-ray, that narrowing of that space. We're starting to see thinning of that cartilage cap, that capping cartilage I showed you in cartoon form. So I would call that a mild arthritis. We'll go on to a more moderate, this could be even classified as severe, but you'll see the next x-ray what is severe. But what we start seeing here is complete flattening of that joint space. See that little bone spur there? Little bone spurs out there? Very much a significant thinning of the space between the two bones, and actually seeing a bright white space in here, or bright whitening of the bone, if you will. And that whitening of the bone is that loss of cartilage, the bone seeing increased load and the bone's hardening up. It's what we call sclerosis in medical terms. Surefire sign that this patient's hurting. This knee's on its way to needing a knee replacement type surgery. And here we see end-stage arthritis. There is no space left between those bones. Just looking at that makes you hurt, I bet. You can just feel the grinding and the mechanical component to that. You look on the side view here, and you can see the kneecap's even involved. This kneecap has no space between it. See all these bone spurs on the knee? I mean, that's the normal edge of the kneecap right there. That's all bone spur that's formed on the kneecap. So that's a knee that's beyond end stage. That knee probably doesn't move very well. The ligaments in that knee are shot. That's a very difficult knee to replace. In fact, you can even see here, this is so severe that the shin bone, the thigh bone is actually carving into the shin bone on that x-ray. It's carving in, particularly on the back side of the knee there on that side view. So that's going to be a very difficult knee to fix, but it can be fixed. Here we have an x-ray of a hip that's showing some mild to moderate arthritis. There should be a thick black stripe in between the socket bone and the ball bone, the ball and socket joint. It's narrowed, but you can still appreciate hopefully a black space in between. So that's mild to moderate arthritis. There's a bone spur forming there on the socket side. We move on to a more moderate to severe type picture. I've kind of outlined this in red. But again, here you don't see much joint space, just a thin black stripe. But now we're seeing some bone spurs down here. Whoops, sorry. Seeing some bone spurs down here at the bottom. Again, this is going to become a stiff hip. This is something that's going to be difficult for you to put your shoes and socks on, to clip your toenails. Life starts to have a more precipitous decline when your hip hurts or is like this on x-ray. Going to have a lot of groin pain most likely. Pain in the front part of your thigh, coming down into your knee even. Here's an end-stage hip. This is severe arthritis, end-stage disease, no joint space. There's this lightening of the bone in here, these cysts that are forming on both on the socket side and this. This hip barely moves. If you try to move this person's leg on exam, their whole pelvis is going to come off the exam table. Okay, they're not going to move that hip very well. That's a tough hip to fix, but again, fixable. And within a few weeks, assuming normal health and no operative complication, that person's quality of life is going to be immensely improved. So what are our treatment options for arthritis then? I like to think of them as non-operative, non-invasive type options where we're not doing any type of procedure to you. Then I have the non-operative, invasive, if you will, where we're doing shots or other procedures. And then finally, we have our surgical options. So how do we treat the arthritis in the early phase? Quite frankly, how does the government tell us we have to treat arthritis in the early phase now? Well, we treat it non-operatively, basically with some simple things. The non-invasive things. I'm not doing anything to you. I'm giving you a prescription like an anti-inflammatory, Motrin, Aleve, ibuprofen, over-the-counter forms, meloxicam, Celebrex, or prescription anti-inflammatories. We're going to talk about some weight loss. We're going to talk about non-impact exercise. And I know it's hard when your hip or knee hurts so bad that you can barely get out of bed and walk. It's hard to go exercise. And then when you're not exercising, it's hard to lose weight. And then when you're not exercising, you're eating, you're gaining. I mean, it just becomes this vicious circle. Okay? But these are things that can help. They're not the whole answer, especially if you have one of those of the ladder x-rays I showed. But these are things that are important to do in the early stages. These are the things I'm going to recommend to everybody. If you're not already doing them, we're going to talk about that in clinic. We have options where we can get you involved with dietary programs to work with weight loss. We have a wonderful surgical weight loss program in our community. In fact, there's more and more evidence suggesting that we ought to put people into surgical weight loss programs before operating on their hip and knee to minimize their complication profile. Some good data out of the Mayo Clinic that I don't think has been quite published yet, but Dr. David Llewellyn presented it recently at a meeting I was at, and they've got some good data up in Rochester, Minnesota on this. So it's intuitive, if we're heavier and more unhealthy, diabetes, obesity, that our risk profile is going to go up. Well, finally somebody put some science to it, and we have some good answers that show we ought to maybe wait on the surgery and from an orthopedic perspective and look at the weight loss options more aggressively up front. But once we've done these things, once we've tried the pills, the non-steroidal medications, some people can't use them because their stomachs don't tolerate them, or they have high blood pressure, or they get swelling in their legs. We can look at some other things like glucosamine chondroitin, which you can buy over the counter. That can help nourish the existing cartilage, if you will. It doesn't regrow cartilage like some people think. None of the joint juices out there that you see advertised at 2 a.m. if you're an insomniac like I can be at times. None of these things have been scientifically proven to work. I don't have any objection to them. Some people have tried acupuncture. Some people go to the chiropractor. Again, all these things are fine if they're help keeping you moving, help keeping you feeling well, and trying to improve your quality of life. Ultimately, the arthritis wins. Okay? Ultimately, these non-operative, non-invasive things up here, they don't work anymore. So what do we do next? Well, now we start getting a little more invasive. We can talk about steroid shots. When we do steroid shots into the shoulder or the knee, we usually do those in clinic. They're easy joints to get into. If you need a steroid shot of your hip, we tend to do that under a live x-ray machine because it's a more difficult joint to get into. And if we're going to deliver this medicine to an area to see if it's going to help you, we certainly need to make sure we're actually in the right spot. So the hip injections tend to be a little bit more cumbersome and require a second office visit to get that done. But we can try cortisone. Steroids come in multiple different types, but the common thing that everyone thinks of is the cortisone shot. Those sometimes will last 3 or 4 or more months, and that's great. If it's keeping you happy and keeping you moving and your quality of life's what you want it to be, and 5 months later your knee hurts again or your hip hurts again, we could consider repeating the injection of cortisone. If that shot makes you feel great for 2 weeks, but then you start hurting again, I would consider that shot to be a failure in the sense that it didn't provide long-term relief, but a good outcome in the sense that we've proven we can make you better. Does that make sense? The shot can at least tell you as a patient that there's a light at the end of the tunnel. Holy smokes, my knee's hurt for 3 years. I got this steroid shot in my knee, and 2 weeks later I feel better. Or for 2 weeks rather, I feel better. That's a good thing. It gives you a peace of mind that there's something that can be done for you after maybe months or years of not having a quality of life that you would like.
The cortisone shots are only temporary, whether it be 1 month or 4 months, they're only temporary.
All of this is only temporary except for that, and we'll get to that.
I was looking.
Okay, so we get through these cortisone shots, the gel shots. Everyone heard of the rooster combs? That's what it's often referred to, or the lube jobs, or the oil changes, or the gel shots, or the jellies, or they come by different names. What those are these are brand names here on the side, but they all fall under this category of visco-supplementation. To be quite frank, there's not any great science to show that they work very well. Tongue-in-cheek, the science that shows they work very well is funded by the same companies that make billions of dollars off of these. I think we're going to see, quite frankly, from the Orthopedic Academy coming out here, if I'm understanding some of the little birdies that are floating around, we're going to see a little bit of a change in the recommendations of how we use these, and it's probably quite appropriate. A steroid shot probably costs the healthcare system about $70. Okay, probably all in, on average, $70, $100. A gel shot series costs about 10 times that. And if it's not proven to work at that cost, we probably need to realign and rethink how we're utilizing those. If you have one of those x-rays that I showed in the knee, by the way, these gel shots are really only FDA approved for the knee. But if you have one of those x-rays towards the latter part, the second and third one where the bone's touching the bone, and you're of the right age and your steroid shot didn't last 3 or 4 months, I'm probably not going to offer you the gel shot, quite frankly, because we've got to be stewards of healthcare, and that's a whole separate talk. But in light of tomorrow's sequestration hearings on Capitol Hill and everything, we all have to be a part of this cost effectiveness of healthcare. We have to realign our expectations as patients, and remember, all doctors are patients as well. And then we have to, as physicians, offer our patients treatment options that have good outcomes at a low cost. Again, value driven. That's the definition of value in medicine. Great outcome, low cost. And if we have something that costs a lot of money that doesn't deliver a predictable outcome, we all ought to think about how we're utilizing that. So I'll climb off my soapbox now on that and get back to the talk. So we've done all this. We've tried the steroids. We've tried the gel shots. You've tried anti-inflammatories. You've worked on the weight loss. You've gone to the water aerobics. You're doing everything you can, and you're still not happy. You wake up in the morning and you dread your day. Okay? Now our options are really to talk about surgery. So the reason you all probably came here was to hear about surgery, but I did want to take a moment to talk to you a little bit about arthritis, what it is, what our options are. Because if we can avoid a surgery, quite frankly, even though I make my living operating, we've done you a service, because surgeries have risks. But I want to take a moment up front when we're talking about surgery, because as somebody that does surgery that is minimally invasive, and I'm a believer in this to a certain extent, and I'll define what minimally invasive means to me in a moment, but as somebody that believes in minimally invasive surgery, I want to make a point very clear. I do not believe in the other MIS, minimal incision surgery. If I make an incision on your leg that's this big or this big, realize an incision heals side to side. Doesn't matter how long it is, it heals side to side. Okay? And if you can't see what you're doing as a surgeon, then you're doing your patient a disservice. So minimal incision surgery. Minimal incision surgery, I do not believe in. I think there's plenty of science out there to show that that's actually not been the correct thing to do, that it's not actually helping people, that the revision and complication rate is higher. And actually one of the leading proponents of this is a surgeon out of Chicago that created a 2-incision minimally invasive hip, and my buddy trained with him up in Chicago for his joint replacement fellowship, my buddy in Raleigh, and I said, Brett, how many of those surgeries did you do with Dr. So-and-so during your fellowship? How many of those 2-incision hips did you do? He said 0. That's the same guy that published all the data on it because he recognized he was wrong. He studied it and recognized he was wrong. So minimal incision surgery is not something that a smart surgeon should advocate for, in my opinion. A incision should be as small as it needs to be to get the job done correctly. My job is to do one surgery for you on your hip or your knee. And sometimes, depending on how we're built, sometimes that incision needs to be a little bit bigger. Okay? Now, the difference is minimally invasive surgery is a good thing. And I can make a legitimate argument that by making a little bit bigger incision, I can cause less trauma to your muscles and your skin and the whole thing, and you're going to have less swelling and less pain by actually making the incision bigger. If I don't have to pull on your muscles and pull the retractors quite as hard, you're going to have less pain and less swelling afterward. That's less invasive. If I can find a way to sneak into your hip and get in between muscle planes and not cut muscles, that's probably going to be less invasive and less painful. And so that's what we're thinking about and looking at when we talk about minimally invasive surgery. And I just want to make that point very clear. There's a difference between the MIS that most people think of, and that's a mini incision, and minimally invasive surgery, which is causing less trauma to the tissues by taking advantage of your own anatomy, understanding anatomy, using special instruments to get the job done correctly through the incision of whatever size it takes to get it done correctly. Y'all following me there? Questions? An incision this big does you no good if your hip's in or your knee's in crooked. Sir?
What happens if you go into a person's hip and you have to cut a muscle? Does it repair itself?
Yes, it does, but the tissue's never the same as what the good Lord put there for you.
Like scarring?
It'll scar in, but generally speaking, it's not going to cause a tremendous amount of discomfort or long-term problem. And by the muscles, fortunately, in most of the hip replacements that we're cutting, even the traditional hips, the small muscles that get cut are really somewhat inconsequential. The larger butt muscles we're splitting, and those tend to heal back okay. Now, there is a set of the deeper butt muscles that you really don't want to cut because that can cause you to have a limp where you kind of lean to the side that's affected. So you want to try to protect those. Those are technical points. And we'll come back to that concept a little bit specifically about the hip surgery in a moment. So these are not the same thing. So what are your options for hip arthritis? I'm not going to talk about hip arthroscopy because that's really not a treatment for hip arthritis. That's a treatment for younger athletic people that we think may prevent hip arthritis. That's a whole different talk. That's more what we call hip preservation. But that is a treatment option for hip pain. Hip resurfacing, whoop, I'm sorry, I keep hitting the wrong button, folks. Hip resurfacing is something I don't do. I don't personally believe in it. I think it gives into a whole question of different types of bearing options. It's actually a bigger incision. It's a little bit more traumatic surgery. There's a whole lot of issues with hip resurfacing that have shown up over the past 3 to 5 years that have to do with metal on metal hips. And you may have all heard of the hips that were recalled and things like that. We can focus on that later. I can answer some questions on that later. But I'm not a big fan of hip resurfacing for a number of reasons, particularly in women. Just don't think that should be a surgery done in women for risks of osteoporosis developing, fracturing the bone that's left in place. There's a lot of, and the metal on metal issue as well. Actually, not really anybody's doing that in our community anymore. Now, hip replacement is something I do believe in. I personally think that the science of this surgery in the 30 plus years, 40 years now, pushing 50 in Britain that we've been doing this surgery, it has proven to be one of the best surgeries done in all of medicine. And it continues to be a great surgery. It is a surgery that will change people's quality of life for the better. When you look at surgeries, you look at the cost, you look at the outcomes, you look at people getting back to work, quality of life improvements, patient satisfaction scores, there may not be a better surgery done in all of medicine. And I'm not talking orthopedics, I'm talking all of medicine. And especially nowadays with our better plastics and bearing surfaces, I think we're really making strides that we can make this surgery something that can be really truly close to a lifelong implant for most people of the age that we're doing it on. A little different with older hips and the processing of the plastics. But from about 2005-ish, perhaps, onward, I think we've made great strides to really, truly minimize the risks of revision surgery and do a lot of great things for people. But we're talking about this, we're going to focus on traditional approach hips. Now that's where you lie on your side during the surgery. So if you're having a left hip replacement, you'll lie with your right side down. Your left hip will be up. You'll be wedged onto a table and securely fastened. Your incision will be on the side of your hip. And then it's dealer's choice from the doctor's perspective how big that incision needs to be to get the job done correctly. More of what we call, that's a traditional approach hip, where we're talking about there's other ways to do that same surgery from the side, but we'll think of that as lying on your side. There are muscles being split or cut during those surgeries, okay? Compared to what we call the ASI hip, people Google it as such. The ASI stands for anterior, which means front of the body, supine, which means you're lying on your back, and the I is intermuscular, meaning you're going in between two muscle planes. You're going in between a muscle called the rectus muscle and a muscle called the tensor muscle on the front side of the hip. Okay, so anterior means we're going in through the front, supine means you're lying on your back, I means intermuscular, ASI. That's all you need to remember is ASI. So what is an ASI-THA? It's a technique. I'm using the same implants that I would use in a traditional approach hip. I've got a little bit different retractors that I use. I use a little different table and positioning devices, but it's just a technique. It's not a different surgery. It's the same implants. And if you put the implants in correctly, they're going to wear exactly the same through both approaches. And this is one of many described approaches to the hip. There's another approach you can do called the Rodinger approach, which is a little variation of that. You can do another one called the Watson-Jones, lying on your back. Those do cut some muscles in theory. And you can do the traditional laying on your side approach, but you can still come in from the front of the hip and cut through the butt muscles, which I don't like at all, because you can end up with that limp I talked about. So there's, gosh, Steve Murphy up in Boston's doing I mean, crazy stuff if you're smart enough and have the right instruments to get into the hip. There's probably at least 8 approaches I can think of off the top of my head. The important part is that you're curing the arthritis and you get the implants in the right position and you use good implants with a good track record. So this is actually not necessarily a new technique. This is a variation of the Smith-Peterson described approach, which is one of the oldest, if not the oldest, described approach to the hip. It's a variation of that. So it's really nothing new. We've been using this approach for fractures of the acetabulum, or the socket, if you will, for years. So what is an ASI-THA? Again, it does require some special tables. I use this particular table here for the surgery. You do not have to use this table, but because I tend to get a little bit of variation in the help, sometimes people that aren't as experienced in orthopedics, I think this is a safer thing for my patient, because I can have Mary, who's in the back of the room, one of our great help at Frye for us, or my rep with the implant company. Depending on the hospital rules, they can manipulate the table, and I can lock the leg in the position I want it. Whereas if I didn't use that table, I'd have to have a helper put the leg in a position, and if they're not accustomed to it, or if it's a heavy leg that weighs more than the helper, we can end up getting things moving, and I think it puts the patient at risk. So this is very consistent for me, but you can do it on a regular OR table as well. This is a patient lying on their back. This right here, if you will, is their belly button. There's a post right there. This is the front part of their thigh. This is their side, their flank, their love handles, if you will. This is their buttock right here. This is the top part of their thigh bone. This is where we make the incision, roughly right here. That's a little bump on your pelvis. We go a couple finger breaths below, a couple finger breaths outside, and we start our incision. And I don't mean to gross anybody out. This is about as much anatomy as we'll get into, but this is the muscle plane here. Okay? All we're doing is going in between this muscle and this muscle. Okay? So most surgeons are performing these traditional posterior approach hips where you're lying on your side. And that's a fine surgery. In fact, I still probably do more of those, quite frankly, than I do the anterior hips. And for somebody that's experienced with a hip replacement, it's a wonderful surgery. And it probably takes me less time to do one of those, and it's less stressful, quite frankly. But we do go in and we do kind of cut some small muscles, and we do split the big, what we call gluteus maximus muscle on the way in. So the ASI is considered a muscle sparing approach because we're going in between those two muscles I grossed you out with on the last slide. I saw a couple people shudder there. We do have evidence, this is long-term data, this is a well-known thing, that any approach that comes in through what we call the anterior side, whether it's the surgery, the ASI surgery, whether you're lying on your side and the surgeon chooses to cut through the heavy butt muscles and come in what we call the front door, any approach that comes in from the front of the hip has a lower dislocation potential, meaning that your artificial ball has a less chance of popping out of the artificial socket, which is an unfortunate complication that occurs with hip replacement. It's occurring less and less frequently than it used to due to advances in technology and better understanding of hip anatomy. However, the traditional approach posterior hip has a much higher dislocation potential than an anterior approach hip. That's science, that's not debatable, okay? In fact, when I was a fellow, we wrote a paper on this and showed that actually you should take it a step further. You should have in your arsenal a couple different approaches to the hip, or just be an all anterior hip person. I won't bore you with the details of that study, but basically what we showed is that people who have higher preoperative range of motion of their hip, which really wasn't a very high amount of motion, it was a total of 115 degrees combined motion. So most of us can still, with arthritis, flex our hip 90 degrees. Then if we turn it 20 and we bring it in 5 or 10, we're above 115 degrees like that. And when I'm trying to dislocate your hip purposely in the operating room, that's the motion I do with the posterior approach traditional hip. So we showed that people that have a higher range of motion in their hip before surgery have a higher dislocation potential compared to those that have a lower range of motion. You with me? So the stiffer the hip before surgery, the less likely you are to dislocate after surgery. Well, then I took it a step further and I said, okay, let's think about this. Who typically has high range of motion in their hips? Women. Skinny women. And the problem is women and smaller, more petite women and males that are thinner and more wiry in their frame have that higher range of motion, but they also have smaller sockets. Just think of it this way. The bigger the prosthetic ball that we put in for your hip replacement, the bigger the artificial ball, the less likely you are to dislocate. You with me?